Alrighty.
Let's start. It's 9:30.
Yes, perfect. Okay, welcome everybody. Thank you so much for joining us today. So my name is Mio. I'm a research assistant with the UBC Addictions and Concurrent Disorders Research Group, and I'll be moderating / tech supporting this session. We'll just dive right in, and I'll begin by introducing our two speakers. So first we have Dr. Michael Kraus. Dr. Kraus holds numerous titles, including BC Leadership Chair in Addiction Research. He is a professor and researcher in the Department of Psychiatry at UBC, as well as a founding fellow of the UBC Institute of Mental Health. Dr. Kraus's main research interests focus on the comorbidity of severe mental illness and addiction, but his past and current work spans across every facet of addiction care. So we're really happy to have him share his information and knowledge on this topic today. Thank you, Dr. Kraus, for being here. I'd also like to introduce Dr. Vijay Sithapathy. Currently, Dr. Sithapathy is the Chief Medical Officer at BC Mental Health and Substance Use Services. In this role, he provides strategic and operational oversight for medical services for a variety of BC mental health and substance use service programs. He is also a clinical assistant professor of psychiatry at UBC and serves on the UBC Psychiatry Executive Committee. So they both bring a wealth of expertise and experience to this discussion, and I'm very excited to hear Michael's presentation and Dr. Sithapathy's leading the discussion as well. So wonderful. Whenever you're ready, Michael, feel free to go ahead and get started.
I'm ready, and here we go. Okay. Given that we have all these number-driven discussions, I suggested to dive a little bit deeper into the issue of drug-related mortality and to really try to address most of the topics. So my objectives are, oh gosh, it's too fast. My objectives are to reflect the management of the most important risk factors and to help to inform the next generation of experts how to address an overdose or opiate overdose mortality crisis as we have. So you saw already these numbers. Right now, the numbers are even higher than Dr. Matthews said. BC is the global hotspot of overdose mortality with 440 fatalities, and that is related to the population size per 1 million population. The US is, as a country, the leading one with 277. Canada has 171 right now, but it's also still increasing. Last year in British Columbia, we had 2,511 fatalities, and probably some which weren't counted and identified. You see, across the world, there is a broad range of that. And I'm not kind of diving into the specific numbers anymore. If you compare different countries here, it's very interesting that with a very simple analysis, you can identify some of the reasons for overdose or drug-related mortalities. If you look at the blue bubbles, they represent a high rate of opiate overdose. If you look at the gray bubbles, they represent a low rate of overdose, and the orange ones are kind of in the middle, and this has to do with specific patterns of use and other things. The x-axis is showing you the average number of patients in OAT treatment per 100 injection drug users. And what you see is in the left corner, you see the big is the US and Lithuania, a Baltic country in Europe. Canada is also there, and Estonia, another Baltic country. And that is also kind of in the is also related to other measures of prevention. But what you see in mainly, I think, main message of this graph is the lower the protection through OAT, the higher the risk of dying of an overdose. And this is a picture also Dr. Matthews showed. This is very often, or as a more or less more than a rule than an exception, is a combination of complex concurrent conditions of several kinds and high-risk substance use. If you look into specific populations, like in the hotel study, which was also mentioned, I was part of, is that the higher the level of complexity and mental illness, also the higher the mortality. People with complex concurrent disorders are living on average 30 years less than the normal life expectancy. So being or suffering from a complex concurrent condition means you're losing life expectancy and die earlier, which is very hard. Also, as part of the problem, also for youth and for all kinds of, the number of hospitalizations are rising, which is a big challenge given that Canada and British Columbia has relatively limited capacities for hospital or acute care facilities and other treatment facilities. And the coverage in terms of OAT treatment is also one of the lowest in the Western world. I'm just mentioning to get a framework. And one of the most disastrous thing, and you heard that in the Redfish Healing Center, 50% of people are of First Nation descent. You see that there are extreme risk factors like social access to healthcare and all kinds, and patterns of use, which are contributing. And we will go through that in detail. But it reminds us how important it is to address these topics in a complex way, and to develop a system of care means to consider a lot of details. We hopefully will be able to at least scratch. Given that this year's Let's Overdose is very also focused on youth, people also adolescents and transitional youth, we have to acknowledge also that the number of fatalities among these in this age group is rising extremely. And I also refer to Dr. Matthews in terms of methamphetamine and crack use is also a major issue, and benzodiazepines, which are adding to the problems using opiates because they are addressing similar mechanisms. Always also mentioning that there is also an effective response. And Switzerland in the 90s was one of my, let's say, early days in being confronted with these developments in the open drug scenes in Central Europe. And there was an immediate and very swift response in terms of change in drug policy, heroin-assisted treatment, and capacity building in that area, and overall sufficient capacity in terms of research and supporting the population, which, if you look at that in the 90s, in the beginning, or the high time of the open drug scenes in Switzerland, as well as other parts of Europe, there was an increase in overdose significantly, a doubling of overdose, which then with a relatively swift response led to a decrease. And so this is kind of just one thing I would like to mention also with other examples in Europe. That is always worthwhile to look, what did they do and how did they integrate the different pieces. So diving into the mortality a little bit more detail and also looking at the physical risk. So, and these are different factors to consider. There is, because of the half-life of fentanyl as the main street opiate nowadays in British Columbia and also in Canada, because of the half-life and pharmacokinetic measures, a lot of people tend to mix it with so-called, which is together called trunk dope. Xylazine is one of the drugs to be aware of. With both have, on the one hand, they prolong the effects of fentanyl, but on the other hand, they also contribute to respiratory depression. So benzodiazepines and opiates were already also in the 90s a major killer. At that time, there were different high potent benzos. And also, if you look into countries like Scotland or parts of countries like Scotland, you see that benzodiazepines and also, let's say, regionally produced benzodiazepines, they're contributing significantly to a rising death toll in these areas of the world. A very important point is also that, or a very important risk factor is, and that's especially true for adolescents and young adults, if opiate naive individuals using, they are at a higher risk because the effect of high potent opiates are much more significant. So if somebody who never used opiate is using one pill of hydromorphone, could fade away, could die of that. And we saw very dramatic pictures like that. In that case, OAT is a protective strategy. And this is not offered to most adolescents, as you saw in a paper by Alinsky et al. In 21, to adolescents and young adults. The expectation among pediatricians and also a lot of psychiatrists is just the only way is abstinence. So that's sad. Also, if you go, for instance, into an abstinence-based program, I just wanted to mention relapse is an ongoing and kind of a normal event in a long-term trajectory of is a chronic condition, as we at least believe, as hypertension or asthma or other things. And you see here relapse rates in terms of medication, behavior, or diet, or whatever, among hypertension and asthma are between 50 and 70%. And in substance use across the board, it's 40 to 60%. If you are abstinent, again, what I said before is kicking in immediately, and you're using something like fentanyl or nitazene or other high potent drugs, the risk of overdosing and even dying is much higher than it was with the street opiates before. So here, probably this graph, just focusing on fentanyl, this has a 50 times higher potency than heroin and 100 times higher than morphine, which is for a lay person nearly impossible to dose appropriately. And that's a very important keep in mind. You may think carfentanil, which is 10,000 times from a specific pharmacological model, but it's in 8% of the toxicology assessments among fatalities, drug-related mortality cases, 8% were showing positive carfentanil, which is mind-boggling. So what is the main mechanisms to understand the mortality of fentanyl is, beside, let's say, pre-existing conditions like COPD, the substances are having a direct effect on the respiratory systems, like benzodiazepines, like alcohol. And it's also important how quickly that is reaching the system, and the combination of the patterns of drug use are extremely important too. That means the people are stop breathing about 15 minutes after the overdose starts. 15 minutes of time to act and to respond. And it's very important to know, when I worked on the streets, more or less, the time between overdose and overdose mortality was 3 hours. So that's a significant difference, you can imagine. Okay, another topic related to mortality, which is totally ignored to a certain degree, is the high level of self-harm and suicide. There is a whole research direction. And there is the evidence-based number right now is analyzing all mortality cases. The guess from the US administrative data is that between 15 and 20% of the fatalities are suicidal in nature, which are classified as an overdose. So it is an important topic if you want to understand also the risk of mortality, to keep that in mind. 20%, that's quite significant. And you have to see it also, there is not very often not one cause. As you know, that people with depression and other complex conditions, there is a lot of fluctuation, and it's kind of it's a gray zone in between. But you need to treat and look for suicidal ideation and so on if you work with opiate addicts in order to protect them. There is, okay. Then the functionality of overdose. So why I'm talking about that, it's also important in any mental health condition to not only understand the dysfunctionalities, but also the functionalities, to understand why are people taking a risk, why are people doing certain things. And obviously, very often, overdose is an instrument of suicide. So that's the other way around, the perspective. And as a consequence of high-risk opiate use, it's important to kind of see how they're doing when they are using, what are the other conditions influencing their lives. And anxiety and depression are the most frequent mental health condition among high-risk substance users. And so, and again, talking about the gray zone, very often people are doing, and then users are doing things which are not really a distinct measure to kill themselves. They are more really about an accident, a not planned accident, unwanted and not calculated, but they took the risk because they don't care really about their own lives, as a lot of people don't. So there is a behavior in between which is not really distinctly suicidal, so with suicide plans and suicide attempts before, but which is more being indifferent to the risks, as we see. If you look at overdose cases, there are common circumstances for these fatalities, which is important to keep in mind. Overdose, very often there is a lack of risk awareness and a high risk tolerance due to existing mood conditions. A lot of people are using alone, which is leading to the risk of not being recovered, and nobody's calling for help. And there are also emotions which are are leading to insufficient self-protection, like shame, social isolation, and with a lack of reflection and precautions. So we try to address that with safe use initiatives, but this has strong limitations. And very important is also to know if there is a history of overdose, I would declare or identify every of those patients as let's say, intensive care patients. These, regardless of the rest, if they once overdose, that is a clear cutoff for every system component to pay close attention and really try to learn from these events and establish a system around them. Otherwise, the likelihood of overdosing again and not surviving is getting higher with every overdose attempt. So it's not to be taken lightly, and it shouldn't be taken as so what are the talking about that, what are potential strategies to reduce mortality? Okay, sorry for this busy slide. I will explain it once because I'm using that also on other. I think one thing is, which is a highly also politicized discussion, is how to reduce the availability of fentanyls on the street, which is to a certain degree a legal question, it's an enforcement question, but it's also, if you look into the Iceland prevention model, for instance, it's a question of how to promote certain behavioral strategies, patterns, public opinion, and there are different ways to reduce it. But I think that is an important line of thoughts and discussion we are not having sufficiently. The second, first green level is to identify strategies for general prevention. If you go into schools, most kids never really learned about risk, about the different substances, and are not really prepared. And that needs to also, beside the general prevention strategy, everybody should experience, especially in the school system, it's also targeted prevention. Everybody who overdosed once should get a targeted prevention package to prevent the next overdose. And that includes media work and specific target groups to address. The third layer is about harm reduction. I talked about that. I would just want to point out drug checking is a good idea, which is insufficiently used because you need qualitative drug checking. You need to know how much fentanyl is in a certain batch and not only whether there is fentanyl in it or not. So the peer mentoring part, I can keep out a little bit here, but it's also an important way to stabilize people. And then the red ones are the core therapeutic strategies like OAT, or substitution treatment with different substances, developing quick induction methods to stabilize people. And then is also how to use different strategies to stabilize patients coming into acute care with physical health needs like broken legs or pneumonia or endocarditis or whatever. And we did a study in a big Vancouver hospital addressing this population, the fentanyl cohort study. You will hear also in others breakout sessions. And is a totally new area of opiate management in acute care, because if you not take care of their withdrawal right away, the likelihood that patients leaving the hospitals in hours, despite their physical health needs, is significant. And so there are different strategies to address that. And then if you stabilize them after that, in the dark green, like there are different things you could do, like opiate antagonists or like so naltrexone depot, Vivitrol, or implants, or other things. And also, that with Sublocade, there is a depot, and other brands are also making available in a different way. If you want to, as a patient, want to withdraw or stabilize, there is also a total set of other things leading then to the lowest cover of recovery. So what I wanted to say, there are different tools to reduce mortality, and there are also a lot of risk related to that, which means you need a thought through integrated clinical trajectory to deal with all these things. And they not turning the risk into zero. So just summarizing again the major therapeutic strategies here: limiting of fentanyl use. I think these are some ideas, and I'm happy to share my slides too, so that you can go through it afterwards in a little bit more quiet way. But I definitely think, for looking especially at schools, there needs to be measures to limit trafficking in schools. There needs to be a mandatory teaching about high-potent opiates and their mortality risk, and less the public tolerance towards that drug trade and availability of high-potent opiates in society, which is a controversy. But I think this is a place to have this conversation. Okay, this is the whole discussion also around safe supply included in that. Okay, then I said drug checking, yes, qualitative drug checking would be important, because the dose you need to kill somebody is so low, is so small, that you can't really, as a non-professional, can't handle these drugs in a protective way. Targeted prevention is, from my perspective, an intensive case management combined with standard relapse prevention programs, as Dr. Message also described for redfish, for fentanyl survivors. They need specific attention, and they need reasons to recover. So back to school, back to work, all these specific measures provided in good care need to be also initiated in the community. Okay, I just want to mention at once, we need a specific strategy for adolescents and young adults as an extremely vulnerable part of the population. As you see here, the numbers are upwards in a very concerning way. I also recommend this way, the CDC dashboard for the different age groups on drug mortality is a very helpful one. Just look it up. You will learn a lot you probably never wanted to know. Okay, so targeted prevention in schools should be part of that, and so on. I mentioned that before. Back, what can we do related to suicide and overdose? I also want to refer to the background issue of functionality of suicide. In some countries, suicide is far more accepted. But think about this. Our students, the smartest kids on the block, report over 10% suicidal ideation in our universities. So suicide is not just a totally marginal problem of some lunatics on the sidelines. This is in the middle of our society. And this is related to overload of stress. And I think it's important to teach people not only English and mathematics and so on, but also teach them to deal with stress and potential failure. And that is not a reason to kill yourself. Okay, and the functionality of the overdose I mentioned already, and there is an overlap we need to be aware of. Potential steps of escalations are very much happening over time. Suicide is a development. It's not only an event, as is overdose. And you have to be aware of the trajectory to be able to intervene as early as possible and to prepare people for coping with their critical challenges themselves. So I'm just put it in again to remind you. I'm not going through it again, but there is a rationale behind it, and we need to read it appropriately and discuss it. So, and we know back to adolescence, suicide and overdose today's biggest reason for mortality among adolescents and young adults, being in a lot of challenges. So just on the side, somebody who likes to read, there are very interesting conceptual models to look into that. So some analytical colleagues actually describing chronic substance use as a chronic suicide. And there's a theory about nearly as old as I am, so over 50 years, which is worthwhile having a look. You don't need to be a psychoanalyst, but it's always inspiring to look at a different perspective. And the same is with cognitive behavioral treatment theories, behavioral theories about suicide and overdose, and all the things around personality disorder. So there is a lot of stuff which is kind of working in this area. So in order to open up a therapeutic path, we need to have a better emergency room. We need to make sure that we are preparing our emergency services in a way and that is as effective as possible. So I told you 15 minutes. That is a very short period of time, and we need to respond extremely quickly. And not only naltrexone, it's about CPR, it's about ventilation, and so on. So it's getting more complex, otherwise we're losing more lives. Safe consumption, I mentioned, is a big one here, and I don't go into that. So because I don't want to continue talking over time. A very important one is actually an integrated continuum. You don't see overdose death as just a one-time event. It has a history, and we need early intervention strategies are only working if we detect the problems early and if we are able to identify risks as early as possible. Okay, coming to the end, hopefully we're able to share some things you didn't know. And in any case, I thank you very much for your patience, and I hope that we are having a good discussion now, which will be managed by Mio and opened up by